I want to thank Dr. Tomaszewski, Dr. Vitale for the invitation. Really excited to have this talk today about management of patients with concomitant hip and spine pathology. As we'll talk about, this is an increasingly common problem, and it's something that we're looking at more and more over time. So as some background, it is actually pretty common that patients will present with both spinal and hip problems. And this is because the spine is actually an adjacent joint to the hip. And so if you have a stiff spine, either due to deformity or degenerative disc disease or spondylosis, or a stiff hip, which is very common if you have severe hip osteoarthritis, it puts more stress and strain on the adjacent joint. So we know this to be clear across the entire body. For example, if you have a stiff knee, the hip above or the ankle below will have to do more to accommodate the decreased motion. And that can cause problems in both the up and lower direction. This syndrome was really coined and described fairly recently, actually. And we found that patients who do have abnormal spinal pelvic motion, which can often, again, be related to either a fused spine that we do surgically or degenerative spinal disease, is associated with total hip arthroplasty instability. And so Dr. Held mentioned hip replacement surgeries do extremely well. This is probably the one problem with hip replacements, is the risk for instability, which is dislocation. Unfortunately, spine fusion surgery in particular is a strong predictor of hip instability, of hip dislocation. And this is increasingly a problem because the proportion of patients who have both a hip replacement and a spine fusion is increasing over time. So one take-home I want everyone to understand basically is that either in a normal hip or in a replaced hip, the socket, which is called your acetabulum, or the metal socket we put in as a surgeon, sits on top of the ball or dome of the femur, sort of like a hat. So in an ideal world, it sits directly on top of the ball of the femur. So when we put a hip replacement in a patient, we seek to have it right on top of where we anticipate the ball will be. What we know about spinal pelvic motion is that normally when you flex or extend your spine, or if you go from a standing to a seating position, your body will naturally try to accommodate for the change in your spinal motion to keep that dome of the pelvis or the dome of the acetabulum still toward the ball of the femur. So if you're looking at the images to the right, if you look at the center, that's a neutral position. So this is a patient who's standing upright, and we have a good idea where that socket will be in 3 dimensions, both for tilt, inclination, and anteversion, which is in the Z direction. If you look to the left, though, and this is a patient who has an anterior pelvic tilt, you can see that if you tilt the pelvis anteriorly, this will actually change the direction or the way that that socket is facing. And this can have ramifications for instability or problems for hip replacement surgery. Similarly, if you tilt the pelvis posteriorly, you can see more of the socket, and it will turn that socket facing more anteriorly. So this can go in both directions. There's many terms for this, and I acknowledge that some of this can be a little bit tough. So some of these slides, as well as some of the background slides, I put in the talk so that if you want to look at the video later, you can look in more detail, but I'll kind of go through the most important parameters here. So this is an image of a lateral view of a pelvis and a hip. So if you look at this image, toward the right-hand side will be the front of the patient, and then toward the left-hand side will be the posterior. So if you're looking at the image here, this is the coccyx and sacrum. So this is the posterior hip, and this is the front of the patient. And this shows you basically how the parameters can change based on the tilt of the pelvis. The 2 main ones we look at is called anterior pelvic plane, or APP. This looks at a vertical axis, trying to define how is the pelvis actually tilting in that Z axis. The other one that we'd like to talk a lot about is called the sacral slope. This is also from our spinal literature as well, looking at basically the orientation of the sacral end plate, which is a good analogy for understanding how is that sacrum tilting front or back. And then in terms of the femoral-sided part 2, we look at the anti-inclination, and this is relevant because this really tells you the sagittal position of both the socket or the cup. And this brings us to how this becomes a problem. So there's really 5 main mechanisms of instability. First is that decreased spinal pelvic motion can lead to impingement due to decreased acetabular motion. So when you go from a standing position, as we all know, you're generally upright, and there'll be lordosis of your lumbar spine, which is where the small of your back is. When you sit down, though, your pelvis will tilt posteriorly, which we all can sense when we're sitting in our chairs. If you can't accommodate that or do that normally, that pelvic area will stay retroverted, which can cause impingement anteriorly, because when you sit, your femur will be flexed up forward. In addition, again, if you have decreased spinal pelvic motion, the femur has to do more movement to accommodate that. Third, postoperative changes or postoperative degenerative changes can alter the functional position of the cup. And the spine surgery itself can take what was previously a well-positioned acetabular component and actually change it so that it's no longer in the correct orientation. So if you see surgeons doing hip replacements in the operating room, we'll often use x-rays to see exactly where that cup should be. And we base this on several parameters to see where the face of the cup should be in 3 dimensions. But if you change the spinal position, that cup that you thought was perfect can now be in an imperfect position. Last is that spinal deformity, even without a surgery, can lead a hip surgeon to place a cup in a suboptimal position. So this is an example. So this is a patient where we're looking at the side views again. We're looking at the lateral view of the spine, sacrum, and the hip. And this is a patient who has neutral pelvic tilt, but decreased spinal pelvic motion due to having a degenerative lumbar spine. So this is sort of similar to a patient who maybe has a very severely arthritic spine or maybe a spinal fusion that gets a total hip replacement. So they have a normal standing position, but when they go to sit, instead of flexing or tilting that pelvis to accommodate the femur, it can't do that. And so you can imagine in that side view on the right, when you flex up your femur, you no longer have clearance or coverage of the ball, and it'll dislocate posteriorly. And that's almost how all hip replacements will dislocate, is posteriorly. Here's another example. So this is an actual example from a patient who had a well-positioned total hip arthroplasty and had a postoperative change. So if you look at the x-rays to the right, you can see on the far left was the preoperative spine, and you can see that the hip and cup is in a relatively good position. You can see that the socket is relatively flat and slightly facing toward the anterior side, which is desirable. This patient had a pretty significant spinal deformity, underwent spinal correction with osteotomies, which was effective for restoring their lumbar deformity, but unfortunately changed the position of the cup. And so if you look at the second image here, you can see that you now have a posteriorly tilted socket. And again, most hips will dislocate posteriorly, and in fact, that patient actually had a posterior dislocation. So there's a lot of data on here. I'm going to go through a couple of these talks in more detail, and then I'll kind of go through some of them quickly. And again, you can go look at these later on in the video or the slides. But this was a really important study. This was a Medicare database study from about 10 years ago, looking at CPT codes for total hip and lumbar spinal fusions, a large number of patients, and they found, as we know, a prior lumbar spinal fusion had a significantly higher rate of dislocation than without a spinal fusion. And in addition, it seems that the number of spine segments fused increased this relationship. So this is what we call a dose-dependent relationship, which means that the more stiff, the more fused the lumbar spine is, it probably increases your risk for dislocation for hip arthroplasty. And we found similar studies in similar findings in multiple studies. Overall, they showed a strong relationship between lumbar spine fusion surgeries and risk of total hip arthroplasty instability. Again, this is dose-dependent, which means the more of the spine that is fused, the higher the likelihood of an instability event for the hip. In addition, extension of that fusion to the ilium or to the pelvis was actually another risk factor. So again, the stiffer the spine, higher risk of a dislocation for the hip. But we didn't look at or understand what matters in terms of timing. Would it make sense to do the hip spine surgery first or the hip surgery first? Looking at some of the small retrospective studies, and I'm going to gloss over these because they're not the highest quality studies, we found a lot of sort of differing data on this, some showing that there was maybe no difference in dislocation, some showing maybe there is a little bit increased risk of a dislocation if you do the spine surgery first prior to the total hip arthroplasty. And some studies looking at it, they found an increased risk of total hip revision, and that was because of having to redo the hip surgery to change the cup mainly. And so sort of differing data on this. Again, another study showing that if you do a total hip before a lumbar spine fusion, there was a higher rate of dislocation. So basically discordant data here. And I think this is because these studies were generally pretty small, pretty heterogeneous. When they combined these studies via meta-analysis, where they basically put all the numbers together to see if they can answer the question better by combining the data, as you can imagine, with very heterogeneous studies, they found that this kind of went out in the wash. It kind of looked pretty even, meaning that there was no big difference in revisions, dislocations, or aseptic loosening when you combine all these together. But there was a big problem with these studies, mainly that these looked at procedure codes rather than diagnosis codes, and there was no time limit between surgeries. It means that you could have a total hip arthroplasty and then 10 or 20 years later have a spinal fusion or vice versa. So these really weren't necessarily the patients that we're talking about, patients with concomitant spine and hip problems, and we're trying to figure out what do you do first. These are patients that may have had totally separate hip and spine issues. And this brings us to probably the more contemporary data that I think did a better job looking at patients who likely have simultaneous spine and hip problems. How do you manage these? So this is a relatively recent database study across payer mix using CPT codes to look for both revision hip and total hip arthroplasty, and then spinal fusion, which is done either 1 year before or after, so relatively short to the hip surgery. In this study, they found that there was no difference if the spine fusion occurred prior to or after the total hip replacement. This was another study that was written more from the perspective of spinal fusion outcomes. And so this was another database study looking at claims data from Humana, looking at mainly risk of failure for spine fusion before or after hip replacement surgery or without hip replacement surgery. And so they split these patients up into 4 groups, either having a spine fusion alone without a hip replacement, having had a hip replacement done 2 years before the spine fusion, within 2 years before, or total hip after the spine fusion surgery. And they found that total hip arthroplasty after the spine fusion had a higher rate of something called adjacent segment disease, or basically having complications of the spine fusion compared to any total hip arthroplasty before, and also without a total hip arthroplasty. So the authors here suggested that total hip before the spine fusion could be beneficial. And I think the reason why is that if you can address the stiff hip and then you perform the spine fusion, you're relieving some of that, again, that adjacent segment stiffness of the hip. You can imagine if you do a spinal fusion and you have a very stiff hip, you're still having to put a lot of force across that spinal fusion. And we think maybe excessive motion across the spine could have led to issues of non-union or adjacent segment disease. And then last, and this is one of the better studies as well, looking at patients who had either total hip, lumbar spinal procedure alone, or before or after. They did find that a lumbar spine procedure before total hip was associated with a higher rate of a dislocation compared to the converse. And here they recommended total hip arthroplasty first. Again, this was not a perfect study. They looked at non-fusion and fusion surgeries as well, but certainly some data that supports some of the findings of the earlier study. So how do we actually use all this information? So I would say this is the way that I think about this, to look at the relative pros and cons of doing a hip replacement before a spine fusion. So we'll start with that category first. So if you're considering in a patient with a stiff hip and a stiff spine, doing a hip replacement surgery first, here's the argument for that. If you can increase the hip mobility, which we can do very reliably with the hip replacement surgery, we might potentially reduce or delay the need for a spinal fusion. There's good data to show that between 30 and 50% of patients who have a hip replacement actually have some improvement to low back pain. Again, that's likely because you're reducing stress across the spine. It also may increase or improve the lumbar spine fusion outcomes, again, by putting this into a more advantageous environment for healing after the spine surgery. In addition, we think that if you do the hip arthroplasty first, the soft tissue around the hip can mature, so that if you do the spine fusion later, and let's say you do change some of the spinal pelvic parameters a little bit, the soft tissue capsule around the hip is healed, which theoretically can help reduce instability. And then last, a degenerative spine might already be stiff, so you may not be losing much by going ahead and doing that order the way it is. Conversely, the argument for doing a spine fusion first would be that the correction of the spinal deformity will set the spinal pelvic parameter so that you can put the hip in the advantageous position. And that's easier to do than the converse. And so you can avoid this category where you have a hip replacement that's done, it's doing very well, you have a major spinal correction that's done, and then you start to have instability. You can potentially avoid that category. So basically, I'd say looking at all the data, and there's a lot of data, so it can be a little bit confusing, but I think the way you want to think about this is that for these patients, you probably want to take an individualized approach. Clearly, the data is conflicting, which means that some studies show maybe it's better for spine first, maybe better for hip first. There's probably a lot of selection bias in these studies. The way that I would approach it is this. If you have a patient with concomitant hip and spine problems, and you anticipate they might need a spinal fusion, I would base it on the potential need for deformity correction, which means that if a patient you anticipate will need a deformity correction which will alter your cup position, probably makes more sense to do the spine fusion first, so that it's set by the time you do the hip replacement surgery. If it's maybe a short segment fusion or one where you're not going to change the spinal pelvic parameters, there's actually good data to say doing the hip is helpful. It'll probably help to improve the outcome from the spinal fusion and also potentially, in some cases, actually obviate the need for additional spinal procedures anyways. So what I would recommend doing is having a multidisciplinary approach. These are patients where we would typically advise discussing between the hip surgeon and the spine surgeon, understanding, for example, with the spine surgeon, how many levels are you going to do? Is this a short segment fusion? Is this one where you're going to do osteotomies? Are you going to change their sagittal balance? And if so, that can help to point you in one direction or the other. Thank you.